Good evening and welcome, everyone. I'm Laura Erskine. I'm the director of the UCLA Center for Healthcare Management. I'm also faculty in the Department of Health Policy and Management at the Fielding School, and we are thrilled to have you here for the Paul Torrens Health Forum. This session will be recorded. It will be made available on the Fielding School's YouTube page a week or so after tonight's event. But before we get started, I want to thank the donors who have made this event possible. And as many of you know, the Health Forum is named in honor of Paul Torrens. For more than 40 years, Professor Torrens guided, mentored, and advised students at our school, helping many to shape distinguished careers in healthcare and public health, and creating a space for dialogue and advancing ideas was really a testament of, or a strong belief of Dr. Torrens. And for those reasons, he created the forum, and we renamed it in his honor, the Paul Torrens Health Forum, in 2016. Additionally, this special session is in honor of Ruth Roemer. Ruth was a pioneering social justice legacy in the Fielding School of Public Health who used the law to improve public health and advance health equity. Few housekeeping notes before we begin. We encourage questions from the audience. We will take questions as time permits at the end of the session or towards the end of the session. This link, this QR code, goes to the Slido page. You can also go to slido.com and enter 418-1582. We ask that you type your questions in there, but also have a look at the questions that other people are posting, because if it's a question that you think is a good question or an important question, you can upvote that so that it might be more likely to be asked. So tonight we have David Feinberg from Oracle Health, Ed Levine from McKinsey Company, and Murali Gangadharan from Cedars-Sinai joining us to explore how organizations are driving innovation within the dynamic healthcare landscape. This forum will examine the multifaceted opportunities and challenges within the industry and will address key questions such as how can we foster innovation in a heavily regulated industry? What transformations can we expect in light of proposed changes to Medicare, Medicaid, NIH research funding? What successful M&A or strategic partnerships have proven synergistic and additive? And what role does technology play in driving change and innovation in healthcare? Following their introductory remarks, Jennifer Heenan of Spencer Stewart will moderate a Q&A session with the panelists. So during the presentations, I invite you all to engage thoughtfully, post questions to the Slido, and reflect on how these changes could impact not just the healthcare system, but also the health and well-being of communities across our country. Tonight, our first speaker will be Ed Levine. You can see his bio here, so I am not going to read it for you. But Ed Levine is a senior partner at McKinsey Company in the Bay Area, and he's joining us tonight from there.
Thanks, Mark. Don't hold the Bay Area against me, but thank you for inviting me here. I'm going to spend a few minutes actually setting up a little bit about why innovation is so critical, given where the healthcare system is and all the players are. My presentation is going to be a little bit more focused on health systems, where I spend more of my time, but I think the comments will be relevant across all the stakeholders. So let me just set that up for you for a little bit. So first, I've been at McKinsey about 23, 24 years, and I've been serving health systems for 20 or 21 of them. And it seems like every year, it always seems like the end is near, that things are going to fall off the precipice. And we certainly continue to see that today. The good news is that for those 20, 21 or 22 years, things have always kind of worked out. But I think there's a question of pulling the old levers only gets us so far. And so that's why innovation is going to be important. We have a constellation of forces that you see on the left with demographic shifts, continued chronic disease burden. I'm going to show you a page on the aging of the population coming up, some utilization shifts from inpatient to outpatient to freestanding to virtual, continued reimbursement pressures because nobody wants to pay what the actual cost inputs have been since COVID, workforce supply pressures, some of which have gotten better, some of which are still there and are likely to be there. And then certainly since the beginning of the year, a lot of regulatory uncertainty that's always been there and has probably been enhanced in the last couple months and probably will continue. And what you see is what's happening on the right. You've seen consolidation of all parts of the industry, especially on the health system side over the last 5 years, really over the last 10 years. Lots of investments in non-acute assets, which is a good thing. Plan sponsors feeling affordability pressure, a lot of payer diversification, and then a redistribution of risk and the early stages still of value-based care. We're not going to spend a lot of time right here talking about it, but we might in the Q&A. So let me show you this. Let's just to get you going on this a little bit. This is a fairly shocking chart every time I show this because the good news is we only age 1 year at a time, which is very good news. The bad news is that where demographics are going in the United States and have been going is a very different place than where we've been. So if you look at the bottom of the chart, this chart is, you need to look at the numbers to realize how skewed this is. The bottom 2 rows are 0 to 24 and 25 to 64. That is the entire pre-Medicare commercially insured for some insurance, population. And if you see the CAGR or the compound annualized growth rate for that population from 22 to 30, so we're already kind of mid-cycle, it's flat. It's flat. You only start to see the 65 pluses, the early Medicare, showing modest growth, and all the growth is in the 70 plus group. And it's shockingly high for that. And you can see, sorry, the numbers cut out, but the numbers in the bar graph represent, in this stacked line chart, represent the net increase, the nominal increase in population in millions for these populations. And it goes without saying, we've got per member per month medical cost of those. You can see how it goes up as you get into the 80 plus, 80 to 84, 85 plus. You can do number of disease conditions that those folks have, number of prescriptions, number of utilization events. It's all the same. So there is an onslaught of utilization and need for healthcare services that's coming for an industry that, again, is struggling to survive every year on what it's already been dealing with. So this is one of the reasons why innovation is so important. We need a step change more than just incremental change to be able to handle what's coming. The other, let me see. Okay, good. So the other thing I want to talk about, I have 2 charts on for many years now, as both Murali and David can probably comment on. There's been a difference between input costs for health systems or any delivery system player and the revenue that they get. And every year there is a 100 to 200 basis point or 1 to 2% of revenue gap that most health systems have to cover just to maintain their margin. What this shows is from 2019 to 2024, let's just focus on those 2. The first bar is these are not-for-profit health systems operating margin in percent. This is first bar is the 25th percentile. This is the median. This is the 75th percentile. So you saw a 4.4 percentage point difference between the 25th and 75th percentile. What you see in 2023 is, first of all, the bottom fell out for the bottom 25th. You see that everybody went down, and the difference between the top and the bottom got wider. So there was a bigger disparity between the winners and the losers. If you constrain yourself to just the top 30 United States not-for-profit systems, the differences are maybe a little bit more subtle. This again goes 2019 to the first half of 2024, but it's pretty clear this is a distribution showing top and bottom quartile and medians. you can see there's a trend, slow, but an inexorable trend downward. There's some bumpiness due to COVID, the relief from COVID, then the removal of that relief, but it's very clear that the industry has seen a margin decline because it struggles to keep up with the existing difference between input costs, a lot of them labor, some of them external spend, and revenue, which is driven by government legislated revenue increases in Medicare and Medicaid, and commercial increases where the commercial group has been unwilling to accept that difference. I don't have a chart to talk about the regulatory uncertainty, but there is uncertainty across multiple dimensions around what is the impact of tariffs that have been announced, what's the impact of site neutrality for payments, what's the impact of changes that might happen in 340B. And suffice it to say that most of those, if played out in the extremes, could dramatically eat into the existing operating margin for most health systems. So let me just finish by setting up kind of some hope here, which is that we see folks trying to use either technology or non-technological innovations to improve operations and the experience across, I've listed here 4 areas. There's probably a lot more, and I'm sure you'll hear some from Murali and David about what they've seen in their experience. Certainly increased patient access and experience. Health systems typically have not done well on this on either dimension, and there's a lot of use of technology and better use of physician and other practitioner scheduling and making it more available to a wider variety of folks. There's core clinical operations that still can be digitally transformed in ways that they've not done, where most of the emphasis has been on just traditional performance improvement. Certainly then more of the back office work, the financial operations, and then the core business functions. So a little bit of a lot for the industry to do, but I look forward to the discussion to talk about how innovation can help. And I believe we're going to turn it over to Murali next. Thank you.
I'm going to invite Murali Gangadharan to come up. And again, you can read his bio. It's very impressive, but I'm not going to waste valuable time from his talk. So take it away.
That's perfect. I'm going to go back to a few of Ed's slides and just really also talk a bit about maybe what Cedars is doing. Anyway, before I start, my name is Murali. I lead strategy and business development for Cedars. Mostly been working in the payer provider space for a while. And the perspective that I'm going to share is maybe slightly skewed. I know Adi Southam is here, who's got a great perspective from a Kaiser integrated health plan, provider perspective, which is very different from academic tertiary quaternary health system like Cedars, which I think has a slightly different perspective. So I think, everything Ed said is spot on. I think that challenges even in LA mirror what you saw from a national perspective. Maybe the demographic trends are, from an overall population growth, LA, it tends to be flat at this moment, but it is still an aging market, which means you have more demand for care, and the capacity in all of LA is relatively limited. So innovation is sort of a huge driver for how we are going to try and solve problems here. So that said, I'm going to add one more dimension to this, which is Ed talked about the input costs, labor, supplies, all of that. But another number that's actually critical is cost of actually building a bed. A bed in LA costs about $5 million if you plan sort of like 10 years ahead. So the capital required to build a hospital and run it with the seismic requirements, with all of the other considerations, is quite significant. So innovation, when we think about, is not just about delivering hospital-based care, like what you're sort of, what is needed to support the demographics, but it's also trying to sort of see how we can, deliver care outside of the hospital, in the home, prevention, I learned something from Kaiser. It's all about trickles of care rather than large doses of care. And that's a important sort of like model for how we think about, need to think about innovation. So I'm going to spend a little bit of time talking about the 4 pillars that Ed laid out and how sort of Cedars is actually trying to, work on those things, and how we are trying to basically sort of leverage innovation as a solution to sort of some of the challenges. So I think the first thing to really talk about is, patient access. I think what is so true in healthcare is, we are behind. People have great experience booking a flight or booking a hotel room or, buying something. We don't offer that same digital experience. And a lot of that is not because we can't implement technology, but we can't do change. The main challenge with access is it's not a technology problem. It is having physicians give up control over their calendar or schedule. And that is a huge barrier in terms of actually sort of digitizing access. And I think we've been on this long journey to sort of like, try and, work with our physicians, really sort of think about workflows, intake, and digitize access. We do that quite effectively in primary care type of services, but when it comes to specialty care, we continue to struggle to optimize how we sort of like digitize sort of our, front door, and how do we create leverage technologies to sort of optimize that front door. I think the second sort of example that I want to really talk about, which touches upon a little bit clinical transformation, particularly around the operations. We've been looking at like lots of technology, particularly AI is a huge sort of opportunity. Ambient listening is a great technology that allows the physician to focus on actually interacting with the patient and use that patient interaction to its fullest potential, and not focus on capturing notes or typing on their computer. And we've done some phenomenal pilots to, show the value. Now we're rolling those type of technologies. There's a whole bunch of them, Abridge, Nabla, DAX. All these are cool technologies that basically allow for, that burnout issue driven by sort of capturing notes and other things to be automated. Another great example of innovation in that space is leveraging AI to optimize intake. So for example, in primary care, we have a solution called CS Connect, where we've basically allowed for digitizing portions of the care where patients are asked a whole bunch of questions up front. Those questions enable the physician to capture a bunch of information that they typically spend time asking during the visit. We use that information to create like a note that can go into the medical record. We also use that to drive protocols in terms of medications. That allows us to create efficiency in how we deliver certain types of primary care, and that allows us to expand service, that allows us to actually change the cost structure of delivering certain primary care services. I think if you look at healthcare, talking about like sort of the operational finance and operational transformation, that's another big area where technology has been transformational. And I think David will talk more about this. Today, a lot of back office stuff like coding, utilization management processes that we have to engage with payers, it's very, very manual. And this is where Gen AI and other tools are hugely helpful in reducing the amount of labor that's required to do that. If you look at any health system, they'll have 1,000 employees that are just doing coding. Can we actually sort of use AI to sort of simplify that using a rule-based process, or using more generative AI to sort of like infer things from existing data? Those are huge opportunities that we're pursuing. So I think innovation is going to be a huge key in terms of how we create efficiency, addressing the margin compression that Ed presented. And so we are going to continue to sort of like pursue those opportunities. One last thing to just quickly touch upon is the other set of challenges that health systems face, like ours, which is an academic system, is our investment in research is under quite a lot of stress, because of the NIH funding cuts and so on. We are now looking at like how to leverage our, asset base. Our assets are our people, our clinical sort of like transformational research platforms, our ability to sort of validate, algorithms and other sort of like technologies within our health system to really create new models of, creating diversified revenues from our existing, assets. So that's another huge sort of innovation to, drive new revenue models or revenue streams is another sort of huge opportunity we're chasing to basically address some of the research deficits that we're sort of going to experience because of federal funding cuts. So anyway, with that context, I want to hand it over to Dr. Feinberg and sort of have him talk through what Oracle and other sort of companies are doing.
Our final panelist is David Feinberg of Oracle.
Thank you. I'm not good with. That's
Yep, yep. If you just hit it, it should go green. Okay.
Perfect.
Yep.
Hey, folks, nice to see all of you. Before I do my talk, I just want to tell you what it's like to be back here. I used to work here. On this stage, I spent time with Nancy Reagan, Meta World Peace, Larry King, Yo-Yo Ma. So a woman here had 2 organs transplanted, a heart and a liver. She was friends with Yo-Yo Ma, and she said, will you come and help me thank the people that had something to do with my transplant? So it was about 400 people when you think of everyone involved, housekeeping, phlebotomy, the whole thing. And everyone got a Tiffany heart when they walked in, and Yo-Yo Ma played, and he did this song that he called Transplant. And I mean, everyone was crying, like it's chaos in the beginning, and then it's just beauty at the end. Anyway, so I'm having all these emotions being up here. And tonight I get to be with Ed and Morali, which I'm really excited about. So here's my take on what we're supposed to be talking about. I would say there's 3 guiding principles if we really want to innovate. Much of what we talked about, or what we've seen, in my humble opinion, is making our bad processes work better, as opposed to what are we really trying to do? And I would say, number 1, and I don't think we've ever done this well in healthcare, is focus on the patient, the family, and the community instead of the provider. Much of everything we saw here, with the exception of access, was, code better. No patient cares about coding, right? It doesn't improve the community of community's health if you do pre-authorization better. So 1, I think the focus has to be patients, families, and communities. The second is we got to move way upstream. I know how to fix access, make people healthier so they don't even come in, right? So that to me is really, really important. And then the way to do it, and I've had a lot of great opportunities to work at different places. When I worked at Google, I learned about scale. And it isn't technology as much as if you make things really usable, tech helps, you can get to a lot of people. When I was at Google, I think it's now 80 billion, but when I left, there had been 50 billion impressions of our YouTube information page on COVID, 50 billion. And if you looked at Google's trust during COVID, in every country it went up. And no one was Googling anything except sourdough bread and questions about COVID. So it was, close to 20 billion health searches a day. And if you get people information in a way they understand, that's where I think tech can be really helpful. I think you can really innovate. So I think that framework can be helpful. My current role, I work at Oracle, and we're global. We're the biggest EHR company in the world by far. When we're done with the VA, we're again the biggest in the United States. And what I say to the team is that means we have more of grandma's blood sugar than anyone else. So now what are we going to do with it? Well, number one, we should keep it safe, and then we got to get it to the right people. Then we have to understand what's going on with grandma's feet and her eyes, and does she have food in the cupboard, and what's happening genetically, and what are we doing to prevent type 2 diabetes in her grandchild, right? I mean, that's the framework that you have to think of, I think, from a tech standpoint. So let me give a couple of examples where innovation has blown me away. So last year I was in the UAE and Qatar. Qatar is one of those countries that is 100% on our software. And they look at pediatric weights to determine if they're going to open a fast food restaurant in that neighborhood or open a gymnasium. And I'm like, whoa, simple, like really, really simple. But they're going to fix obesity by not letting kids get overweight and just looking at the data. Now, the next story, which is about patient-centeredness, we screwed up as a company, but I still think it's a great story. So in Sweden, they're replacing an electronic health record. Sweden has, like, they call them regions, but think of them as 5 big states. And in 2 of the states right now, we're going live with our new electronic health record there. And it's replacing an old record that they've used for a while. And we bought that company. So it is technically our record. So we're showing them the new record, and the doctors are really upset because our electronic health record does not allow you to prescribe opera. And the old record does. And they're telling us how valuable it is that when patients come in, they can actually prescribe, in this case, the opera or other social services. Now, we did a workaround to make it work in a drop-down menu or pharmacy, but other places like the UK, when you see the slides that Ed showed, and the other one that everyone likes to show is, we spend 20% of GDP and we have the worst outcomes. The part that's missing on that slide is all these other countries that are spending 8, 9, 7, 10% on healthcare and have better outcomes are also spending 8, 9, 10% on social services. We spend nothing on social services. So we combine it together, and then we tell health systems, who are very ill-equipped, with a few exceptions, you guys figure out homelessness. You guys figure out food insecurity. You figure out what to do with people that don't have access to education. You figure out what's going on with people who have problems with transportation and loneliness. So it's really not fair, because you should say we should compare our 20% to that 8 and 8 or 10 and 10 that the others are doing. I'm not saying we do it well, but we just don't spend on social services, and instead we medicalize it. That I have seen as I've gone around the world is a huge problem. And then the final piece, that it's so eye-opening. Every place I go to outside the United States, I go into the conference room. People go around the room, they introduce themselves. I'm the chief medical officer, I'm the chief medical information officer. And they say to me, you're from the US, and our problems here, and this could be Australia, New Zealand, the Middle East, the UK, Sweden, Germany. They say, our problems are completely different than yours. Healthcare is different here. I said, so what are your issues? Well, we can't keep nurses. The wait times in the ER are really long. Supply times cost a lot. And I'm like, oh my God, how unusual. Do we have a solution for you? So I think when humans build health systems, you end up with some of the things that are very similar. The one difference is you never have to talk about value-based care. Everything is value-based care, because in that room is let's call him, the person is the head of healthcare, and they have a budget. And when you say we can take better care of people and it costs less money, the first thing they say is, how fast can you roll it out? When I have those conversations here in the United States, with a few exceptions, there's a bunch of other discussions. You mean that means there's going to be less patients in the ER? Or what about our volume in our ambulatory surgery center, right? So that value-based care, we call it that here, is actually what everyone else does around the world. Now, some of them have kind of another layer of private practice. Okay. Just so I earn my keep, let me tell you what we're doing at Oracle. So this is the commercial part. I'm giving you informed consent. I am paid by Oracle, right? That's my job. But I think it actually describes a lot of things that are going on in the industry. So 2 things we've done. We have fixed the electronic health record. So it works like this now. Patient gets a text that says you have an appointment next week, Wednesday at 1 o'clock. Normally, you got 3 options, press 1 for yes, 2 for no, or 3 to change the appointment. We said, well, that doesn't make sense. Let that person, back to how other industries have done it, let that person write down anything they want. So this patient wrote back, well, I need my metformin refilled and I need the blue pill refilled. And I'm a little nervous about giving my kids vaccines because I've been reading a lot of stuff in the news. I'm going to make the appointment and I have some new onset vaginal bleeding. Okay, that was the response to you have an appointment on Wednesday. So what does the AI do? The AI figured out all 4 things. So one was the blue pill, figured out what it was. It actually isn't for that doctor next week. It was for another doctor. That doctor's on vacation. The covering doctor got a note with about 3 sentences that allowed that doctor with 1 click, never having to go to their inbox, refill the med. The metformin, the AI figured out, would be figured out in the appointment. But what about those 2 other things? Vaccine hesitancy and abnormal vaginal bleeding. So the abnormal vaginal bleeding, the AI agent figured out that there was room in the schedule to increase the appointment by 10 minutes, so there would be time to discuss it. The doctor, just about to go see the patient, says, hey, Oracle, tell me about my next patient. You get 2 or 3 sentences that summarize it like a really good med student, but it's not just from EHR. Right? So if I were coming here for my appointment, it should also say that I've been exposed to fire a couple months ago. That's not in any of my electronic health records, but could be very important. So this doctor gets the summary of what's happening on that patient from 2,000 public data sets and all the EHRs. And it says patient wants to talk about abnormal vaginal bleeding and has new onset vaccine hesitancy. Then, as Murali described, you come in the room, you put down the phone with the patient's permission, ambient listening does it. But it's not just ambient listening. I need to say to the, I can't remember last time, did this patient have anxiety and shortness of breath? Did this patient have their hemoglobin A1C change when I increased the metformin? So you can do inquiry in the middle of visit. Hey, Oracle, what was up with the hemoglobin A1Cs? And then at the end, all the actions, billing, coding, note, referrals, all that stuff is done for you. So it has summary, it has ambient listening, inquiry, and action. And it's the same for the patient, and it's same for the case manager who says we're behind on mammography screening for my 5,000 at-risk patients. What would it take to set up a campaign? And it tells you the cost, how many people you need, et cetera. Just voice. The doctor never touched the computer. So that's one, really excited about it. The second, and no one's ever done this in healthcare, is build an end-to-end platform that connects everything. But it's actually been done in every other industry. So what we mean is back office things like ERP, supply chain, actually Cedars, UCLA, both putting in Oracle back office. How do we make that clinically informed? So what we do is we say this nurse has been certified to give chemotherapy, but that was 2 years ago. And because of staffing, the nurse ended up working on the neurology unit. But today is the first day in the oncology unit. And we bring just-in-time training in because we know that from human capital management before the nurse gives it. Or when I'm done in the operating room and ambient and voice captures my note, it also drives supply chain for next week because it understands the entire kind of system of the hospital. So we're building that end-to-end platform, and we're making it open and connected because we think that all the innovation will come from the ecosystem, the insurgents that we want to build on top of it. So now I think we all hang out. Is that right? Okay, thank you very much.
Access to the QR code, but I'm about to turn off the projector so that it doesn't shine in our panelists' faces. So if you haven't logged into Slido, do so in the next 5 seconds.
Thank you all for those presentations, very informative. So I'd love to start with a question, and you just gave us, both Murali and you, David, a number of innovations that you all have been focused on. So maybe next I'll ask about, sometimes I find that my biggest learnings come from failures. So I'd love to hear about when you were trying to innovate with your respective organizations and when it failed, what you learned.
I got a good one. When I was at Geisinger, we had a health system in New Jersey, and it was doing really well in Atlantic City. And we were going to expand to a neighboring town. I forget what it was called, but it's the blueberry capital of the world. And we bought this big mall and we converted it into a big outpatient center. And we thought it would be really cool, because I'm all about patients, if there was no waiting room. Because the moment you came in, we would know from a thing on your car, and then we would tell you, welcome in on your phone, and, you know, physical therapy can see you now, and then you'll be ready for your blood draw, and then your primary care doctor's ready. And we had all this amazing stuff. The patients hated it. We ended up having to build a waiting room in the place that had no waiting room. And the learning was that for a lot of people, going to the doctor is an activity, and it's, especially for the elderly, back to your slides, it treats a lot of loneliness. That person at the front desk in the waiting room is a human connection. And we screwed up and we lost it. And so, I mean, we had done some focus groups, but back, someone mentioned already here, Kaiser has a real innovation center. I think we really should have built a mock center, had people come through, and I think we would have had that learning. But that was an expensive capital mistake. I thought it was cool, and it turned out to be terrible.
I'll jump in, sort of maybe another sort of example. One where we failed before and now we're doing it differently, and sort of we're seeing a different outcome. So about 10 plus years ago at Cedars, we started a program called Healing at Home, which is basically, you know, trying to sort of deliver acute care at home. And I think, you know, we failed from multiple perspectives. It was a well thought out program. We used a playbook that was developed by Johns Hopkins, and, you know, tried to implement it. I think the challenges that we didn't anticipate, one, not all patients were comfortable, like they wanted certain care in the hospital, and we couldn't always convince them right at the ED that you can go home and we'll get you the same level of care to home. I think the adoption there was a challenge. Second, we couldn't convince our physicians that you could actually sort of like provide this level of care safely in the patient's homes. And we couldn't convince the payers that you should be paid, you know, if not acute care level reimbursement, some reimbursement that's better than a physician visit, you know, at a clinic. And, you know, COVID changed a lot of that, because I think people have gotten really comfortable with virtual care. People have gotten comfortable with digital care. So RPM has become a big factor in how you can monitor a whole bunch of things. Payers have become really comfortable with the idea that a higher level of care can be delivered and reimbursed appropriately. And the federal waivers from Medicare and others have been a huge enabler for that. And, you know, now as we sort of think about that, we look at that as an important sort of pillar in terms of how we address our capacity challenges. The demographic sort of impact that Ed talked about, I think those are real. I mean, it fills our hospital. Like, I think Reagan is pretty much running 100% every single day, if not more. And that's the story of high quality tertiary quaternary facilities. And so we now, you know, focused on, you know, all the stakeholders and managing expectations. And, you know, we are able to sort of like really look at how we deliver that higher level of care in patients' homes. That's an example of sometimes time and other factors also help innovation.
Okay, I was just going to comment on hospital at home, because just to key on, obviously I'm not an operator, but I've seen folks try to start at home offerings, and I think there's going to be a place for them eventually, because I think we're going to get over the patient family acceptance of care at home and the practitioner, whether it's physician or nurse, Right now, though, those that have tried it have been very disappointed in the economics of it. And it actually makes a lot of sense, because why do we have hospitals in the first place? We have hospitals in the first place because we are consolidating expertise, high cost talent in a specific spot. And when you do at home, for most places, maybe LA's, or the high density places like LA, it could make sense. But in most other places, it's a diseconomy of scale to put high cost practitioners traveling around to individual houses. So I think technology in the way David was describing that already exists in the physician office, if that could be brought at home, which one day it may, that could help, because that will enable then a non-human traveling miles on LA city streets or freeways to do that. But until that happens, I think you've seen a lot of people try it and then back away from it because it's been fairly disappointing.
So just remember, when hospitals were originally built, rich people got care at home. Hospitals were built for poor people because they couldn't get care at home. Now we put rich people in the hospital and keep the poor people out. So these things come around. So we'll see how it goes. And the biggest problem back then in hospitals when they first built them was infection control. Like nothing has changed. We just swapped the socioeconomics in the building, but we're still getting infection.
Great. In thinking about some of the innovative initiatives that you've been a part of, that you shared in your presentations earlier, I'm interested in the secret sauce that enabled you to have an impact. And maybe it changes with each initiative, but can you talk a little bit about that?
Let me start. I think a recent initiative that we pursued is trying to sort of deliver 24/7 primary care in a new cost structure, new sort of like care model, and sort of integrating that with our primary care practices. I think the challenge we have in primary care is, coming out of COVID, we had 3-month wait time to get a primary care appointment. And that was not really sort of like acceptable. And we were also facing burnout with our physicians who were working, extra to just address the access challenges. And one of the big things that we drove in that innovation in terms of integrating virtual care or creating a new virtual care model was focusing on workflows to not like look at virtual care as a isolated thing, but look at virtual care as a complement to brick and mortar primary care. And we focused on change management, we focused on integration, we focused on technology to drive efficiency. But at the end of the day, it was meant to be patient-centric. So patients were put at the center. We made sure our physicians and all the providers were coordinated, leveraging the technology that was available by sharing information across all of these providers. And I think in many innovations, sometimes, you focus on deploying technology. You forget about, the workflow and the human sort of side of it and the change management side of it, aligning incentives, aligning sort of the right metrics to sort of drive improved performance. Those were some of the big sort of lessons as we sort of deployed a model like that sort of changed the access paradigm.
I would say, to double click on what you said, Murali, it's 100% in my experience has been when you can tell a compelling story, win the hearts and minds of the folks that are going to make the change, because this is going to make it better for patients, families, or communities. When I was here, we took patient satisfaction from the 28th percentile to the 99th percentile. That was 100% by telling stories, and then people agreed to kind of they bought into the change management. At Geisinger, we created the largest biobank in the world, whole exome sequencing with return of results. That was because we had a stable population and had an ability to tell families of 30 members that came to us, 15 of you are going to die from this cardiac arrhythmia that we found. We can save your life. That drove it. We started a fresh food pharmacy that now serves 5 million meals a year to type 2 diabetics and their families that had food insecurity. I keep saying it's really nutrition insecurity. They had calories, they just had bad ones. But that was because those were our people and the incentives were aligned because we were an insurance company. There were a lot of things going our way, but it was always around, hey, can I introduce you to this patient or this family or this community member or same day access? Let me explain what happened when this patient called us and how we failed, and then capturing the hearts to do all the things you just said, Murali. So I think I think we get lost in healthcare, looking at our own navel and not serving those that we have the privilege to care for.
Yeah, what I was going to say is, I think what's underappreciated because of the complexity of the systems involved and the different stakeholders involved in any kind of change is the change management. And you can have whiz-bang technology, but if the end users don't change what they do, none of it really matters. And actually, just adding on to what both David and Murali said, we have just a pretty simple framework for change management around how do you get like thousands of people to change their behavior. And it's like four things. One is there a change story? Do people understand why they're doing this, and is it compelling? Does it speak to them? Two is this role modeling. Do they see, you need others around you, your more senior folks, including all the way up to the CEO, sometimes role modeling the behavior. Three is, are there formal incentives for doing it and disincentives for not doing it? You can play with that. And then the fourth thing is, have you given people the right skill set and capabilities to do it? And so much of what we do, we don't hit all four of those. And if you do, and oftentimes if it's a groundswell of it's been created by the front line, you can see really interesting innovations come through. When it's imposed from above and you don't hit those four, it's very likely to fail, because you don't need, most of this change is not decision-based change that a senior executive can make. It's really thousands and thousands of people working for an organization, changing their behavior. That's what makes change happen.
That is so valuable. I used to pay so much money to get McKinsey advice, and we just got that for free. That's amazing. That is really a great framework. McKinsey's always been good. To me. Totally. They have saved me many a time, but it's just a really nice framework.
Thanks for that, Ed. So according to a 2024 study by the Commonwealth Fund, the US ranked 10th in health system performance when compared to 9 of our peer countries. Yet we're always seen as a global leader in medical and biotech innovation, and we have some of the top hospitals in the world, including UCLA and Cedars-Sinai right here in Los Angeles. So why is there such a disconnect? We heard we're not spending on social services. And how do we get people engaged in their own health? And in particular, how do we reach out to communities that are less connected, may not have technology, or are less advantaged?
Well, I think we are spending on social services. I think it's just the wrong people spending. We're having the health system spend instead of people who actually know how to spend it. So I don't think we're spending wisely. But on the connecting out to real folks, we have a thing called the Learning Health Network, which we basically say to our customers, do you want to, for free, turn over your de-identified data to us, to this consortium, and in return, you get access to all the de-identified data, and you can do studies. You can also participate in life sciences and pharma trials. And what we've seen, we have over 100 million records, 100 plus health systems. Half of them are research naive. They're places that have never participated in academia. I'll give you an example. For in California, San Joaquin Hospital. It is not UCSF, Stanford, UCLA, Kaiser, or Cedars. It's San Joaquin Hospital. They're now on their 3rd cardiac trial. They have never done clinical trials. So it does a lot. It gets a much more diverse group of folks into the trials, which is very, very helpful. It's particularly just a migrant farm working community. The other thing, so pharma likes that. The other thing it does is those docs are now comfortable with using the device or the medication because they were part of the trials. If we go back to when those people were excluded from the academic things, You'd get great care at the academic medical center, but it would have taken 17 to 20 years to get to San Joaquin Hospital. And so we think actually getting folks involved in research in communities from the beginning does a couple of things, and it's been a great business for pharma because they get a better diverse group. So you got to go to where the people are. And I give different examples based on where I am, but Osmond, Nebraska has a population of 80 people. The general hospital there is one of our best now in clinical trials. They had never done clinical trials. So I think there's huge opportunity.
Yeah, so your question's a really tough one. I mean, there was a lot in there, and I think it's a vexing problem that has been around for a while, and I'm not sure we've seen as much progress as a system as we would have liked. Part of what we have to grapple with is that because we have a complex system that has complex funds flows, complex sources of funding, every player, it's not just the health systems, every single player has certain incentives to kind of keep things the way they are. That includes the payers, that includes the government, for some that includes private payers, that includes physicians, that includes nurses, it's every single player. So unsticking that has been very hard, even when it's obvious that certain things should be done. The other thing that I think is clear is that it can't, like you said, David, and I'm sure you would agree with this, the health systems can only do so much. They're not the right folks to solve some of the social issues, the social determinants. They're interested in it, but they're not necessarily the right folks. My only maybe whiff of optimism here is if you go back to my chart about which populations are growing, we're going to see more and more folks in the Medicare age range. And Medicare becomes a really interesting place for people because whether you're in Medicare Advantage or Original Medicare, at a certain point, the incentives can be aligned. We're going through a tough period in MA right now because of the payers ended up kind of upside down with their medical loss ratios. So they've been, it's just been a lot of tension between the commercial payers that have MA plans and the providers. I think after hopefully we get beyond that, I think there can be a lot of collaboration in that group and maybe even in the Medicaid and the duals to actually do things that are similar to what David was describing happen at Geisinger. So I think there has to be some sort of change because the incentives are so fixed for people to just stay the way they are. And we've not figured that out in this country, how to unstick that.
Thank you. AI is being used in many ways in healthcare, and Murali, you highlighted a couple of them with optimizing intake in primary care, ambient listening. Interested in hearing from all of you some of the other interesting or promising cases you've seen and how likely you think that those will go mainstream across the country.
So when I was at Google, we on top of Cerner in the NHS, we developed an app to try to help the rapid response team in the hospital diagnose acute kidney injury faster and published on. And so typically it was taking 4 hours for them to go see a patient whose creatinine had come up, a measure of kidney function. So we gave them a phone, no AI, and the phone told them the creatinine went up and it went from 4 hours to 14 minutes. There was 30% less cardiac arrest and a 17% decreased cost of care. So that's just good UX. Then we did AI. So we looked at 70,000 patients, 600,000 variables per patient. And this was supervised learning. So AI's even come farther than that now. And we trained the computer to be able to diagnose acute kidney injury. So it was normally taking the nurse 4 hours. We got it to 14 minutes with the nice phone. The computer did it in negative 48 hours. So 2 days before any signs or symptoms, with 90% accuracy, the computer said this patient who looks fine, has normal labs, is going to be on dialysis. They were right 90% of the time. So it was like mind-blowing. I think it's the field of anticipatory medicine. I think we literally could write people's medical records. I could write your record for the next 10 years. And here's what it says. And if you want to be at your kid's graduation, we should get your blood pressure under control because the medical record shows you're having a stroke the year before the graduation, right? I think we're at that level. That's the cool part. The scary part is that training data was actually a VA training set. The VA is 93% male. When we tried it in a general population, 50% male, 50% female, it didn't work. So as these tools come out, I don't mind if somebody screws up a doctor's note. Doctors screw up their own notes, like whatever, we'll tune that, ambient listening. But as we start getting into clinical decision support like this, we have to be very cautious that the training data is appropriate for the use case. And if there's bias in the training data, the computer's really good at continuing the bias. If there's people who haven't ever come into the health system and therefore are not in the training data, we have to be careful when we use it on those people. If you have your breast read in the United States, but it's trained on breasts in Japan, which are more fibrous, we're going to miss cancers. So how do we use this amazingly powerful tool in a way that says, use it in this population, don't use it in this population, and be careful in this population? I just think that that's an important piece in this.
So let me touch upon an area where I think AI is going to make a significant impact, which is really in workforce enablement. So workforce enablement. So as an example, today, broadly sort of speaking, there is shortage of like sort of healthcare workforce, and we are not creating sort of enough providers considering the demand that sort of Ed again talked about. I think there is huge opportunity, and I'll give you an example use case. Just one of our partners, you know, they've created sort of point of care ultrasound that can be used in combination with some AI guidance to allow a non-provider, like it doesn't need to be a physician, to do certain procedures on a patient. Really sort of using sort of the feedback that the ultrasound can provide, that a particular provider or individual can be trained on a particular procedure, you know, through, you know, just a shorter training program to get them to do certain things quite effectively. That's a great example of how combination of certain digital technology sensors combined with focused training can change the needs of, you know, healthcare delivery by sort of introducing new participants to the workforce. That's sort of one example. Another really interesting research that is going on at Cedars is today when you do robotic surgery, just about every aspect of that surgery is being completely recorded. Now, you know, there's a lot of difference between the skill levels of surgeon A versus surgeon B based on, you know, how they're trained and how sort of like, you know, they do certain procedures. If you can record all of that and compare, you know, the outcomes after the surgery and then start like basically providing a feedback loop to the surgeon saying, you know, you did this particular motion, you know, in the you know, during the surgery, and if you'd done it differently, the outcome could have been different. I mean, that's, and again, a huge application of AI that sort of allows surgeons to improve their skills continuously, and the data is available. The technology to do that in real time or close to real time is now becoming real with all the advent of like, you know, the chips that are available to process that. So those are examples in which you're going to use AI to improve, you know, outcomes by, you know, improving, you know, the training and sort of feedback. In other instances, we're going to create new categories of providers that did not exist that are going to leverage technology to do certain things quite effectively that will augment healthcare.
I'll give a decidedly non-patient facing example here, but I think it's actually where
Pre-authorization.
no, close, close. That is where I'm kind of going, which is we're seeing some of the fastest adoption of some of our clients of Gen AI solutions to writing appeals letters to payers for initial denial. So a payer can deny a claim on a commercial claim on whatever basis, if their claims payment system thinks something's wrong with the claim or it was unauthorized or not medically necessary. And then the providers have folks that will manually go through often with physician input to kind of justify find out was it really justified. So Gen AI can actually do a lot of this on its own under supervision, and we're actually seeing a fairly rapid adoption of that. Now, on the other side, on the payer side, they have human integrity programs that are also human. You see these army, this is what's kind of, hopefully one day we'll get to a point where we don't have
So
armies.
here's
So
how
you're going to
we're-
have Gen AI versus Gen
Yeah.
AI in the future.
So here's how we're thinking about
How
it.
you- yeah.
We just talked about this week. So what if we said to the doctor, your note's done, it's 100%, it's, you know what? Everyone was mad at their banks like 10 years ago, and then banks came up with free checking. I'm sure it's not free, but it seems good now, and I can take a picture of my check and it can get deposited. Like, we're not mad at the bank anymore. We need free checking or whatever the equivalent is in healthcare, and making this process, which AI is fine for, is just making our shitty process fight harder. Like, it doesn't solve the problem. So the way we're thinking about it is Oracle Financial Services processes 80% of the world's credit cards and non-healthcare. And when you think of credit card processing, that's a deal between a merchant and a bank that you have the credit. That's what you bought. It's not fraud. Someone didn't steal your card. Okay, we'll process it. And then the processor takes their percent. We're doing the same in healthcare. So the way we've set it up is we talk to the payers, we talk to the providers. Like when I was at UCLA, we'd make a deal with Blue Shield of California. We'd shake hands after we would fight for a couple months, and then we would each go load the system in our own thing, and we'd interpret it differently. And then we would spend $400 each fighting a $35 claim, right? And that's healthcare in America. So we said, we'll load it as the intermediary. You folks, payer and provider, can audit it. Our AI agent knows both sides. It knows what's happening in the office. It knows the rules that the employer-sponsored payer or the payer or Medicare or MA has. And as the doc's note is prepared using Ambient, we put things in that if you can answer these questions up front, automatically approved, 100%. So cool. We just fired a bunch of people on both sides, coders and deniers. But for patients, because it is patient facing, for patients, it means I went to the doctor and I could have an Uber experience. When I'm done, I walk out and they say, you owe $15. Do you want to pay with your HSA or your Venmo? And you never, ever, ever get an EOB at home, which no one knows what they are anyways. So it would be, oh my God, I know what it costs me to go to the doctor. I never have to say, is this approved? I never have to ask permission because we built in the system at the point of care. So that's how we're thinking about it. And I do think it's patient. Patients hate the system.
Yeah.
So we're not quite there yet. And we're basically doing what you said, the fighting back and
Yeah.
forth, but that's where we're trying to get.
Yeah, and you're one of that, what you've described is amazing, and I've heard others, there's other ideas
Yeah.
similar to that out there. So hopefully you and others will be
Totally,
successful in this.
totally.
Because real-time adjudication of claims and walking out, like, you know, you go to almost any other professional services provider, you know immediately what you owe. And healthcare is the one where it often takes 30, 60, 90 days. And an EOB, for those that don't, is the explanation of benefits, which is what you get from, the patient gets from their insurance company trying to explain what was paid and what wasn't.
I have an MD, I have an MBA, I've run insurance companies, I've run provider systems, I get EOBs at home, I don't understand them. So I just think about folks that don't have the same medical literacy. I mean, you have no idea what they say.
I mean, just on this conversation, I think sometimes the incentives are also so perverse. So when interest rates started going up, the denials rates for providers started going up. It's quite simple, like, you know,
Float.
And that's an example of perverse incentives that sort of like, you know, create more friction in the system than not.
Technology is moving quickly. Fast forward 10 years from now, what types of companies do you think will be driving new innovation in the healthcare industry?
Oh, I think both incumbents and insurgents. You know, the big tech has to pay attention to healthcare because it's such a big part of the economy. But there's folks out there, startups that I think are just doing incredible stuff. I think also that a lot of the innovation is going to come from within the provider side, because they got guys like Morale that are tapping into it. And you automatically have trust, you understand workflow, like that innovation from within. So I think it's going to have to be, to meet Ed's scary slide of what's happening, it's going to have to be everyone.
I want to talk about a little bit about the partnership model that we are pursuing more and more. I think, the idea of a pure play outside in tech player coming in, disrupting healthcare, I think to a great extent has been proven to be a failure. Amazon tried it, Apple, Google, everybody has tried it, a version of it, and that's been a complete
Wait,
failure.
can I interrupt for a second?
Yes.
So people say that, but Google gets about 5,000 times more medical searches than UpToDate or anything else. Doctors go to YouTube before they take out your thyroid, before they take out your parathyroid. So the doc says, don't Google, but the doc is YouTubing to figure out how to do the surgery. So there are examples in, I think tech has made a play in the pharmacy side. And I think tech, the old EHR companies, digitize the record. So we haven't got the good stuff yet, but the patients go to Google.
David, I
yeah.
completely agree with you. Patients go to Google, and I think that's fantastic for Google's, classic business model, just to sell ads. If I look at sort of like, if I look at any sort of D2C company today, one of the biggest line item of expense is customer acquisition. And Google is outstanding, Facebook is outstanding, all these sort of like, entities are outstanding. But I think when you think about like, how do you take that technology and drive, as you sort of pointed, patient-centric change, cost structure change, outcome change? I think the idea that you can do it from the outside to a great extent has been proven to be short-sighted.
Correct.
And I think a partnership model sort of changes that dynamic. It basically brings that capability, that talent that often doesn't exist inside a health system. We often can't find those type of engineers that need to work on those AI problems. We often, the other side is also true. Google or others don't often have data that sometimes, the health systems have, or Oracle has, because of the partnership that you have with health systems. So our new model is, co-develop, co-create. And, in many cases, we are willing to actually put capital and other resources to sort of see how we can create value and start getting sort of like, overall sort of like outcomes improve.
I'm with you.
Just to follow up on that, we've seen an erosion of trust in the medical establishment. And how do you, when you talk about whether it's a partnership between a tech company and a provider that maybe has the trust, but you're also talking about, ambient listening and, maybe patients being a step away from their provider. So what does the future look like in terms of patients having trust in their physicians and in provider organizations?
I mean, we think about this all the time. Organizations like Cedars or Mass General or UCLA, these are 100-plus-year-old organizations that have like really worked hard, delivering outstanding care, creating connections to their community to earn the trust that we have. It's the physicians, it's every individual that, works towards delivering that healthcare. I think we are trying to figure out how to leverage that trust, but also leverage all the technology and modernization that needs to sort of like, happen to the core processes of delivering healthcare. And it is a fine balance. It's very easy to digitize everything, have a breach, and sort of like completely lose trust. So that is a risk that, exists in the modern world, but we are continuing to sort of like, figure out ways in which we can thoughtfully, carefully work through that.
Yeah, I say healthcare is people caring for people, and it's built on trust. And that's it. That's the whole game. And as you said, then you can bring the tech in, but it's got to be, it's a people business and it's got to be based on trust, like, or it doesn't work.
Can I ask one more question, Laura? I want to talk about proposed cuts to the NIH and how you see that impacting innovation in medicine, and also what it could mean for the pipeline of physicians and scientists in the future.
No, nobody wants the answer. I'll start. I don't have a great answer to that. I think I work with a lot of academic medical centers and their cognate schools of medicines and universities. And it's a huge time of uncertainty right now. We've had since the 40s and 50s, we've had a bargain, an agreement between the federal government and higher ed that's created the modern research university that we've enjoyed in the United States. That's been this greatest collection of universities anywhere in the world because of the way it's structured. And what's happened over the last couple months has questioned whether that will continue or how it will continue. So I think as an industry together, we're going to have to figure out, is there going to be a shift from federally funded, centrally government funded, but with a lot of flexibility on the university side to use the money using peer review, what's most, important in the basic sciences, to something that's different that maybe has more private funding. We're going to need to, as an industry, figure that out. And I think there is worry about how do we then preserve the careers of physician scientists and of just pure scientists while that happens. So I don't know if you guys have.
So I think you're right, but just to make the discussion fun, let me take the other side. So with the actual NIH fund cut is on indirects. The way it works, and I don't remember exact number, but if we got a $1 million grant at UCLA for direct cost, we had some inflated number like 67%. So we got $670,000 to pay for the building that the 1 million was taking place in, and other not direct costs of the grant. The reality is that indirect money was being used for a bunch of other stuff. Granted, taking care of people that come to the ER that are unfunded. I mean, it wasn't like we were getting rich. So NIH says, we're not going to give indirects like that. We're going to cut it to 15%, which is what every private institution does. So if you looked at it by itself, it actually makes a lot of sense. And they have said that savings in indirects, we're going to put back into direct research. So theoretically, it's an increase in research. Those are just talking points, right? Like, we'll have to see how all this plays out. And then they cut a bunch of other stuff too that's makes you scratch your head. The question that I have is the right way to fix potentially these interconnected systems incremental, or do you blow up the whole thing like it seems like it's happening right now? And then you probably have some terrible casualties along the way, but can you build things up then in a way that's better? So I don't know. It's pretty scary, and it changes every day. If we're wrong and we lose all the scientists, that's not like just saying, oh, we can now buy computer chips, we can't buy computer chips. If people stop going into science and they all move to the UK or whatever, that'll take us 20 years to then fix. And that can't get fixed if they all move and then next Thursday we say, no, joke, it was a joke. So it's high stakes. But specifically on the NIH drop, there's actually some rationale behind it if you had blinders on.
I think the challenge, broadly sort of speaking, is sort of in domains like radiology, where for the past 10 years, people have been talking about, AI is going to replace radiologists. This meant like less and less people are going into that domain. And today, the impact of that is really hard to find radiologists. Hospitals struggle with imaging capacity because of that. And there's just a whole dynamic of workforce. That's the worry that we have, is that, this uncertainty is going to create like quite a bit of concern, people entering the profession. And how do we, there's no real great answer for it. We're all sort of struggling with the problem. Some of what David talked about is stories on both sides.
Yeah.
Sometimes, places like California, cost of infrastructure is quite high. That warrants a certain higher FNA, recovery rate. But, there are parts of the country where the cost of infrastructure is not that high. You could have a lower recovery rate, but, across the board, 15% sometimes does not factor in sort of the geographic differences, seismic, so many other factors.
Okay, so I'm going to ask one of the more popular audience questions. What can we learn from Maryland's experience with hospital global budgeting to drive innovation and improve population health?
I mean, it's definitely a great model just to sort of start. I mean, actually, one of the sort of things that stood out for me about Maryland in the global budgeting is how MA is not popular in Maryland. Like the idea of like Medicare Advantage as a model for delivering, care through commercial is not popular because, you have global budgets, even a traditional Medicare model, can actually work. Because sometimes you don't have the same sort of incentives that you have, like, with risk coding and other things that sort of, exist in MA. I think it's an interesting model, but you are talking about like changing across the board, the system and all the stakeholders and their alignment. So it is a fundamentally a different model that hasn't worked in any other part of the country, but versions of that are going to have to be tried as a way to sort of control the cost curve.
I mean, to me, it's a balloon. You could squeeze two parts, but you can't squeeze all three. Like, you're supposed to have high quality, accessible, low cost healthcare. Name one other thing in the world that you get that everyone gets. It's really high quality and it doesn't cost money. I would come up with one example, but then I proved myself wrong. I thought firefighters, like you always get a fire person to come to your house. They don't seem to cost a lot of money and they're really good. And then there were the fires in Malibu and people have private firefighters. So I'm like, my example doesn't even work. So, okay, we can squeeze the cost, but then what happens to access and quality, innovation, all of it?
You talked about the impact of technology on trust. There are a number of versions of this question from the audience. There's value in the patient-provider relationship in terms of outcomes. And so what concerns do you have with replacing that direct patient-provider interaction with emerging technologies?
Well, I have no concerns if it's via the provider that they still trust, that they're using the tech. But there's a lot of things that have gone the way of the provider to now direct to the consumer, that people are happy they can get their Allegra at the pharmacy and they don't need a prescription, right? I mean, so if we can, do tech that's really good to do your strep throat and you don't have to bring your crying baby in for an ear infection, I think moms would sign up for it. So there's low hanging fruit where I think the tech can take some, to Murali's point, some work off the workforce so they can do the more complicated. I mean, the tech to me is fantastic, but the real discussion is, you have prostate cancer. Do you want to do watchful waiting or do you want to have surgery? Right? That's where we now have to have the discussion. Let the tech do all the work for me so I can have that discussion.
Yeah, I agree with that. I think that it's not about replacement of the human interaction and the caregiver part of being a physician or a nurse or anybody else in the healthcare system. It's about augmentation. And it's about a step change in productivity of the system, because you can treat a lot more patients for the same number of hours worked when you use the technology versus when you don't. So that's the way I think you thread that needle.
Yeah, I say radiologists won't be replaced by AI, but radiologists who don't embrace AI will be replaced because it makes you a better radiologist.
Okay. What steps do you expect health systems to take in ensuring technology, AI, other of these innovations is digestible and usable by populations such as the elderly or low socioeconomic status folks who lack the health literacy to be able to interpret the output?
So we think about this all the time as we are developing and deploying anything. And I think, sometimes it's actually sort of thinking about standards. There's a whole range of ADA and other sort of standards that we sort of use in designing our applications. We think about like accessibility and other sort of factors that, from a design perspective. But I think, we're also becoming more and more thoughtful and sensitive, or we're more thinking about technology as a solution to some of the challenges. So a great example, today on your phone, you can switch your language. You can switch from English to pick a language. And all of a sudden, your entire interface can actually be changed and can work in sort of whatever the language you pick. That actually allows us to create like access to a whole range of services that otherwise we would not have been able to access. So sometimes technology is a friendly sort of like thing to allow us to sort of, deploy technology or deploy certain services to certain communities or certain segments of the population that may not have had that access. Sometimes it's language, sometimes it's other sort of things that we can optimize for certain age segments. But I think this is going to be, we continue to think about this particular problem, and we look at multiple dimensions as we design our solutions and, ongoing topic.
One thing about, at least for Gen AI, for patient-facing Gen AI from providers, one thing that a lot of folks that have adopted that are realizing is that when physicians write messages back to patients, they are often very short, very to the point because they have no time. The Gen AI writes a much more empathetic, caring message than the physician does. So it actually makes it more digestible, and actually the AI has more time on its hands, if you will, to create a message that actually might be more understandable. So I think it goes the other direction, which is actually it's more likely to create something that can speak at the level that can communicate well with a broad population or in a different language even than the physician. So I think there's a lot of opportunity here. It may go the other direction. It's actually be better in many ways.
It can also help professors to sound nicer.
Actually, we had a startup in our accelerator program that we send out like messages to patients to comply with certain mandatory screening or other requirements. Typically, those things go out as emails, and typically the response rate or compliance rate is quite low. A startup sort of like helped us create a video of the physician sometimes speaking in the patient's native language, asking them to go get a colonoscopy or whatever the screening is. And we found the compliance rate to be really, really high. And cost of producing that video was very low. We just had to get the physician to record a bunch of things, and all of a sudden we could customize the message based on what the program was. Those are great examples in which technology can be used to thoughtfully deliver a message in the medium that we think can drive better outcomes for the patient.
Okay, I'm going to ask one final sort of rapid fire question. Can you point to an early stage health tech company or two that are making meaningful progress on clinical operations transformation?
I think, one area of clinical operations that I think we all struggle with from a healthcare perspective, in the hospital perspective, is really how do we maximize the utilization of our capacity, be it operating rooms, be it, sort of clinics, be it like, any other expensive resource within healthcare. There's a whole bunch of companies in this space, without sort of like necessarily sort of calling out any one company. There are a whole bunch of them that really apply that, AI and other sort of like, Q theory and other sort of operations research technology to maximize how expensive capital resources can be utilized. This can be applied in imaging to maximize the capacity of like MR, CT, those type of like technologies, ORs, clinic and other resources. And that's a great example of like, to give you a name example would be a Leantas would be a name of a company that applies a lot of like intelligent technology combined with sort of like change management and other sort of consulting services to really drive a maximization of available capacity.
I was going to say exactly the same thing. It's the companies that are using real-time data, some AI on top of it to help manage utilization of the impacted areas of the hospital, or the really expensive real estate, or the areas that are where demand always exceeds supply. And then there are other companies that are working on just overall workflow management for nurses and managers, and creating alerts when things are need to be addressed that are real time. It's companies like that. I don't want to say any names, but it's companies that I like that I think there's a lot of excitement about.
I'll name companies. So one is Optane. It's a company that uses a form to capture a picture of your retina and then does AI diabetic retinopathy. It's not yet approved in the FDA. It is approved in other countries. And you can diagnose diabetic retinopathy. And I know from my Google days, you'll be able to know blood pressure, patient stated sex, cardiac risk factors, Alzheimer's disease. It's the only way to see the vessels in the body is through the eyes. So that's one, and it's taken off. And another one is a company called Intus, INTUS, that does analytics for PACE programs and is having spectacular results in PACE, which is kind of a forgotten part of healthcare, but a very important segment for those seniors that need daycare but don't need to be institutionalized. And theirs is using AI learning.
I want to say thank you to Jennifer, to our panelists, David, Ed, and Murali. Thank you to you for coming. Just before you go, this is the kind of event that Paul Torrens believed that a public university should engage in. So we're thrilled that you're here. This is the last forum of the academic year. The health forums will resume again in fall 2025. If you are associated with the Health Policy and Management Department in any way, don't forget to buy your tickets to the annual Leaders of Today, Leaders of Tomorrow dinner, which is about a month from today on May 20th. So please enjoy your night, get home safely. Thank you for coming. It was good to see all of you.